Hey everybody, this is Dr. B, and today's topic presented to me is this opiate addiction treatment medicine will save your life. Real quickly before we move on, this channel is about empowering your long-term recovery with medication-assisted treatment, harm reduction, and science in order to support us and get lots and lots of great videos related to this topic. Please go ahead and subscribe and push the notification bell. We would really appreciate that. And again, as usual, they break it down into a couple of questions. The first question is, what type of medications do you recommend for opiate addiction treatment? Second question is, how do these medications help control opioid addiction over time? What does opioid addiction treatment look like at your facilities? I'm going to, as usual, sort of reinterpret and repackage these questions so I can answer them the best where it fits the most amount of people. Always remember, I'm doing the best I can here because every individual patient is different. That's one of the concepts that I use in terms of harm reduction of treatment. But I'm going to start with the first one. What types of medications do you recommend for opioid addiction treatment? So if this question has to do with initiating opioid addiction treatment when someone has recently been using, it's going to be a little bit different than what kind of medication do I recommend for long-term opioid addiction treatment. If someone is sitting in front of me and they have been let's just use something, heroin or fentanyl. It really doesn't matter. And if I make a decision that this patient is going to need medication-assisted treatment, I'm going to do what's called a clinical opiate withdrawal scale and transfer them from their fentanyl, heroin, or oxycodone to a buprenorphine product. It takes a little bit of skill to do that because you can put them in precipitated withdrawals, but I try to do that with most patients personally myself, or I give them the medication, give them strict instructions and follow them home. The real question is in that initial stage, from when they stop their opioid use to when you put them on buprenorphine products, do they need any supporting medications to make that transition easier? There's a couple of things you need to understand in that initial stage. Number one, you don't go into full withdrawals before you start a buprenorphine product. You have to only get about, maybe halfway, 60% into withdrawals before you start that product. So from when you stop your use to when you start the buprenorphine product and start to feel better, the question still is, do you need anything during that time? And most of the time, I haven't myself personally used very much, but sometimes I do. And it really depends on that when I make that choice, it really is client or patient dependent. And if I can if I'm going to be managing it myself, I am much more prone to add a few medications because I can watch and I can do this probably better than they can to make sure that they're comfortable and they don't go into withdrawals by giving the Suboxone too early. Some of those medications that I add, I always think about and choose medications in terms of their benefit versus risk, how harmful they are in the short run and the long run, including their abuse and addiction potential. Some of the stuff that I like, ibuprofen 600 milligrams, baclofen 10 to 20 milligrams. I will sometimes use very low dose of clonidine. I will also potentially use a very low dose of Zyprexa. These are very tailored to exactly what I'm doing. I am hesitant to give benzodiazepines unless if it's under my control, and because the patients don't really go into that kind of severe withdrawals. So that's what I do in transitioning patients from the stopping point of opiates to starting medication-assisted treatment. And medication-assisted treatment is my cornerstone treatment for opioid addiction. Now the question becomes, after you start MAT, let's say we're going to do Suboxone, and it's 2 or 3 days and you're stabilized on 16 milligrams, 24 milligrams, 12 milligrams, whatever. The real question now is, do I add any other medications? And the answer is this. When the patient comes to me and they're like, well, I have anxiety now, and I also have sleep issues, and I also have depression issues. First thing I do, because they might not be on the Suboxone or low dose or an appropriate dose or no dose for a variety of reasons. First thing I do, I tell the patient, let's get you on the right medication, which is the Suboxone or buprenorphine. Let me watch you closely over the next few days, and let me see where you land. Let me get to know you. Let me understand what your needs are. Is there truly insomnia that's sort of underlying all of this? Is there really restless leg or cramps or anxiety? And given what I find over those next few days, if the client sticks with me through that time, then I may start 1 or 2 additional medications. And those aren't, to me, those aren't necessarily addiction treatment directly medications. Those are secondarily or sort of satellite issues that need to be resolved and put in place. For example, I have a patient right now that takes a very, very low dose of Zyprexa in the evening for sleep. They're under a Suboxone, a certain amount of milligrams, and they also happen to be on 0.25 of clonidine in a day. I spent 2 to 3 months sort of titrating that to make sure that it works for them. And how do I know it works for them? And how do I know there's no abuse? Number 1, the doses are very low. Number 2, I evaluate the risk and benefit of every medication. Number 3, if you're going to be on something like a benzo, for example, you're going to have very close monitoring and follow-up by me. And it's also made very clear to you that, if I see any signs of misuse or abuse, please understand that this medication is not a right, it's a privilege. And if I see you doing well, you're going to move forward and we keep you on that medication. So the cornerstone of therapy for opiate addiction for me is medication-assisted treatment, which is a buprenorphine product. In the initial stages, depending on the patient and how much access I have to them, I might add a few medication to help from that time that you stop the opiates to when I start the medication-assisted treatment. Afterwards, I usually like to wait a few days before I consider adding any additional medication. All medications are added with the idea, what is the benefit, what is the risk, and the concept of harm reduction, which is I want to empower you, educate you, meet you where you're at, keep close follow-up, and absolutely no judgment. The next question, which we can lead into, is how do these medications help control opiate addiction over time? It's a great question. And again, the cornerstone medication is buprenorphine. How does this help control over time? This medication should be titrated to clinical effect in a 24-hour period. What do I mean by that? I see people taking it. Oh, I'm having withdrawals. I'll take some. Oh, I'm going to start tapering down immediately. Number 1, how you take it every day, the clinical effect should be you have no cravings, you have no withdrawals, and if it's for pain, the pain should be well controlled and adjusted and assessed by the clinician that's using it as such. What that means is in a 24-hour period, you should kind of have a routine of however the clinician decides that how much you need to take and when you need to take it. So none of those things pop their head because you obviously don't want withdrawals. You obviously don't want cravings. Number 2, what this allows over time, if we're dealing with, let's say, opiate addiction, this allows your brain, your frontal cortex and your midbrain to heal. What do I mean? When you're on this medication, it suppresses all of the machinery of the midbrain that is actively seeking opiates and has been hijacked. Once you seize that sort of hyperactivity of seeking the drug or getting high or feeling those receptors, Now your brain has time to think, so to say. And I'm really simplifying this, but really this is the science of it, and I'm putting it into sort of layman's terms so you get it. So I'm sort of putting this in basic layman terms so we can all sort of have a common language to speak about this. But essentially, I'm dampening the effect of the midbrain in its seeking the opiate. What this does allow another part of your brain, the frontal cortex, to sort of start to execute what's called executive function, and allows the midbrain and that frontal cortex to rebuild their connection. It allows your pain receptors to sort of get readjusted. And all of this over time actually changes the pharmacology and the structure of your neurons and what's called synapses. In short, let me put it in real simple terms, it's allowing your brain sort of to heal. I'm a little cautious using that word, but it's rechanging it to whatever normal was. So over the long run, this is why I often say to people that if you have 1 year, 2 years, 6 months, 3 months clean, and some stressful event happens and you go ahead and use for one night, that should not be called a relapse. It's an episode of use. That doesn't mean you need to go into detox and lose your whole life. It's an episode of use. We've had months, weeks of being clean if you're on medication-assisted treatment. During that time, your brain has been restructuring and rebuilding to give you the tools to make good decisions, and hopefully you don't go on a run. And each case should be evaluated on a case-by-case basis. And this is how it sort of ties into the idea of how does this medication work for addiction treatment in the long run with opiates. And that's how they control it. And the third question is, what does opiate addiction treatment look like at your facility? Basically, what I just said above. At my facilities, at my programs, what I do is I have a few models, and I'll start from the top down. The first model that I approach addiction with, although I'm a physician and a clinician, nowadays my real interest lies in the sociology of addiction. And I look at addiction as a symptom of a much more deeply rooted social pathology. I won't get too much into it, but I think corporate capitalism and all of its manifestations throughout all of society are causing, in a very, very sort of abstract way, what's called anomie, which basically means loneliness and isolation. I think these are responsible for a lot of the issues that we see, especially mental health issues, anxiety, depression, and addiction. So I approach it in that way. And why that's important in my treatment and my facilities is I try to do something very, very important to healing, which is build a human connection. I want to make sure everyone understands that it's an individual and a team connection here with you. It's a professional one, but we actually do care. I actually do care. My whole team cares. They show that regularly. And that itself helps build a trust and a rapport that's conducive to healing. From there, I am extremely interested in concepts of harm reduction, medication-assisted treatment, and the science of all of this. So flowing down from that, it's important that this is truly a patient-centered, empowering interaction without any judgment. These are all harm reduction concepts, as well as they lend themselves to the idea of social pathology. Now you can actually have an opening after you've built this trust to educate the patient about what is addiction. They kind of trust you as you educate them about the medication. You implement the medication, and then the psychosocial behavioral component that you have, if it's a PHP, IOP detox, now becomes a lot more effective. And what's critical there is that you really get a truly professional team that's implementing that part of the care. Not to say other people aren't professional, but one of the things I have found in this industry is that I think there's a very low bar set for licensing at times, so that people can sort of hand out therapy or individual care or whatever it is. Again, I'm not saying there's not good therapists or group leaders that don't have PhDs. There's many, many of them. But in general, what I've seen is that this care has to be very, very, very fragile in its approach, considerate, and really understand what they're doing. So all the way from the top, from the sociological model to the medication-assisted treatment, to the harm reduction approach of putting a patient in the center and empowering them, to the groups and individual meetings where I really work hard to have a very solid team that we work together to come up with the treatment plan. We discuss the medication-assisted treatment. We also very much all engage in their behavioral therapy, whether it's individual or groups. And that's what I try to do at my facility. Whether it's in my clinical office or whether it's one of the facilities, whatever level of care, we always try to incorporate every one of those ideas. Addiction is a phenomena of social pathology. Harm reduction, which meets the patient where they're at and is empowering and educates the client. Medication-assisted treatment where it's appropriate, science, and hopefully we get great outcomes. I hope that answers all of your questions. I have a ton of videos regarding all of these topics. You can start off by clicking right above to my left. In addition, please go ahead and click the subscribe button as well as the notification bell if you like the contents that we're giving to you. Have a great day.